All right, welcome back, everybody. We are here for our 245 session titled Interventional Radiology Treatments of Metastatic Disease, and we are here with Dr. Amol Mujoomdar. We thank you so much for being here, Dr. Mujoomdar, to teach us today about this very, very important topic. Dr. Mujoomdar is the Division Head of Vascular and Interventional Radiology at London Health Services Centre and St. Joseph's Healthcare, and a professor of interventional radiology, oncology, and medical biophysics at Western University in London, Ontario. He went to medical school in Saskatchewan, completed radiology residency at McGill University in Montreal, Quebec, and completed a vascular and interventional radiology fellowship at the University of Toronto, UHN. His clinical and research interests are in interventional radiology, including local regional therapy of hepatocellular carcinoma and a neuroendocrine tumors along with liver imaging. Dr. Mujoomdar is a former board member and a past president of the Canadian Association for Interventional Radiology. We can't thank you enough for being here with us, and I'm happy to pass it over to you.
Great. I just want to make sure you can hear me. That's awesome. Okay, so I'm just going to share my slides and we'll jump right into it. Excellent. So thank you for inviting me to present on this topic. I very much enjoy these type of sessions. So hopefully everyone will benefit from the content. And if we have questions, for sure, please include them in the chat, and I'm happy to address them afterwards in the Q&A. All right, so I've been tasked to talk a little bit about interventional radiology treatments for metastatic colorectal cancer. And so in my role here at Western and at London Health Sciences Centre, treating cancer is a big part of my practice in interventional radiology. So hopefully we'll be able to work through some of these things. So these are some of my disclosures. Probably the most relevant is work with Boston Scientific, who's the big manufacturer for Y90. So objectives, I was hoping to kind of illustrate the role of the interventional radiologist in patients' care for patients with cancer, particularly with metastatic colorectal cancer, and kind of differentiate a little bit the role between the diagnostic and interventional radiologist. And then I was going to review the different IR treatment modalities for this condition, which might be sort of diagnostic in terms of things like biopsies, curative, or helpful to facilitate other treatments, things like portacaths, or we'll talk about, kind of a different procedure called portal vein embolization, or some of the more palliative procedures that we do to kind of help people at a different stage of the cancer. So if we kind of take two steps back, what's the role of the interventional radiologist? Well, there's a physician who's really interpreting the diagnostic imaging, and I did spend 5 years learning how to do that, or 4 years learning how to do that, sort of looking particularly in the setting of colon cancer. We're talking about things like CAT scans and MRIs and ultrasounds, and that's a diagnostic radiologist. But then within that specialty of diagnostic radiology, the physician who performs kind of quote unquote image guided procedures with ultrasound, CT, or live x-rays that we call fluoroscopy, that's the interventional radiologist. And within interventional radiology, some of us have kind of used this moniker of interventional oncologists that really specialize in cancer therapy. So you might meet an interventional radiologist at sort of different points along the journey. Okay, so sort of early on around the time of diagnosis, or perhaps at the midpoint of treatment, where would you really meet an interventional radiologist? Well, the most common thing would be if you saw someone to do a liver biopsy, or a biopsy in general, but particularly a liver biopsy. That tends to be a common point where you'll meet a radiologist, or usually an interventional radiologist. Interventional radiologists like myself are usually the doctors who are kind of installing these devices like portacaths for people who need chemotherapy, sometimes PICC lines, but less so these days. Our kind of nursing teams tend to do more of the PICC lines. Or you might see us if you have kind of smaller liver metastases, and we do a procedure called ablation, which I'll talk about and explain what that means. Or you might meet an interventional radiologist to do an arterial therapy, where we're delivering different types of things through the arteries or the blood vessels to the liver, particularly to treat liver metastases. Uh, One thing is called the Dabiri TACE. I'm not going to talk so much about that because we don't do that procedure, and I don't want to speak about something that I don't do, just because I can't give you any kind of real world information. But I will talk about Y90, internal radiation therapy, or CERT, which we do a fair amount of here. In fact, one of the biggest centers in Canada for Y90. And we'll talk about portal vein embolization, which is a procedure we use to help a liver surgeon operate and kind of make things safe. But then we can also kind of extend, along the journey of cancer. Sometimes we're doing procedures that are less so in that kind of aggressive era of treatment, and they're more sort of to help palliate people in some of their symptoms, and to help support them at a different stage of the cancer. So we commonly will put in these, we call them ascites drains, for people that have fluid accumulation in their abdomen from the cancer that spread to the abdominal cavity. The same thing for people that have that in their chest around the lungs. So we will sometimes put these catheters that will drain those collections and allow them to be drained safely at home by home care. Sometimes we're placing stents, colon stents into the colon for people that have colon tumors that are really unresectable but are presenting with a bowel resection. So they're not candidates for an operation. So we put a stent in there to allow, or to kind of relieve that obstruction, and to allow for kind of some symptom relief. And then we're doing things sometimes where we're draining bile ducts or draining kidneys in people that have advanced stage cancer and have blocked the drainage of their liver, either from spread of the cancer to the liver, or liver metastases, or spread in lymph nodes around those bile ducts, or spread in the abdomen in general that will block the drainage of the kidneys. And then sometimes we're doing different pain intervention procedures, where if people get a metastasis or spread of the cancer to their spine, that can be painful. So sometimes what we'll do is we can inject cement into those vertebrae or bones, or we can do an ablation procedure there to help treat people's pain. We can do different nerve blocks or freeze kind of nerve ganglion for people that have chronic pain, and do different types of ablations for that indication as well. Okay, and then there's kind of some miscellaneous procedures in IR that you may meet an interventionalist, because lots of people who have cancer, whether colorectal or non-colorectal cancers, they're sort of prone to developing blood clots. And so they, sometimes in the course of their care, they may get an IVC filter placed, which we tend to kind of own the market on those. Or in really significant severe scenarios, sometimes people will have a significant clot that will migrate from their legs into the pulmonary arteries just past the heart, and cause quite, significant, hemodynamic effects that are showing up with, difficulty breathing or low blood pressure, and can be in extremis. And we, do procedures to kind of emergently suck out the blood clot from the lungs, to kind of try to basically bridge them and get them out of that emergency situation, and allow blood thinners to kind of do the rest. So if we start off with kind of very simple and basic things that an interventional radiologist would do, is something like a liver biopsy. So this is a nice kind of cartoon image of showing, how we would kind of poke through the skin using an ultrasound to kind of see the liver, because the ultrasound is a great imaging tool to see the liver, and usually to target a tumor in the liver to make the diagnosis, right? Because we see something on a CAT scan, or we see something on an MRI, but at the end of the day, in many instances, we need that tissue to be looked at by a pathologist to make the diagnosis. And not only just make the diagnosis, but they'll use that information to kind of be able to offer patients very personalized cancer therapies, right? So they can do what's called proteomics and genomics to look at the different things that are expressed by that cancer. So we can not only give the generic treatment that we would give to other people in that stage based on studies, but we can really look on a personalized level and say, hey, this tumor is expressing these particular genes or proteins that we can target. We call them actionable mutations, right? They're things that we have drugs that can target. So the biopsy is a very important piece, not just for confirmation that this is cancer, not cancer, but even to help sort of target the therapies. So this is kind of another image where I don't know if people, can you guys see my mouse if I'm circling my mouse? Excellent. So this is an ultrasound image. This is kind of the closest part to the skin, and this is kind of the skin of the person. And as we can go deeper, then we're going deeper. And then this organ here is the left lobe of the liver. And, we can, hopefully you guys can imagine there's a nice black circle here, okay, that we would, that's how we generally would see, right? So we would kind of look, and that's our expertise or training as a radiologist, is to kind of look with an ultrasound and find this tumor that we saw in a CAT scan or an MRI. And we can see this kind of black, structure in the left lobe of the liver. And then we say, okay, I can sort of place my probe and freeze the skin and kind of guide this needle and see it in real time. The beauty of ultrasound is a real-time imaging modality, and be able to do the biopsy. And I'm not a pathologist. I'm really just in this particular scenario, I'm sort of like the pathologist's hired gun, right? To kind of procure these tissue samples, and then we send them off to pathology where they process them and they look at them under a microscope. And I don't even know what all this stuff means, but the bottom line is they look at it. That's their expertise, is they look under the microscope and they're able to make the diagnosis and do some of the fancier testing. So it's usually an outpatient procedure that's done with local anesthesia, sometimes with IV sedation, and it's generally well tolerated. And really this will kind of diagnose and stage, and as I mentioned, we'll be able to provide some hopefully personalized information about that individual person. The other thing that's sort of a very routine and common procedure is many patients with metastatic colorectal cancer require chemotherapy. And in order to administer or systemic therapy, I should say. And in order to administer systemic therapy, particularly intravenous systemic therapies, you need a good, stable access. And we have different options that we can do, but I would say it's very common for patients to get portacast. It's a very nice procedure for people because once the incision heals, everything is buried under the skin. You just have to put a little emla cream to numb the skin, so when they access it, it generally doesn't hurt, and they can administer chemo, they can do blood draws, so it's a really nice thing. And you don't have the limitations when you have something sticking out of your arm or sticking out of your chest, that you can go shower and swim and do whatever you want without the worry of infection, right? Because once after the incision has healed, so you kind of have to wait a little bit before you can do all that. But once you have a nice healed incision, you don't have to worry about it. And that's what it looks like on a chest x-ray. You can see this device, which is the reservoir and the tubing that's kind of tunneled under the chest wall and then fed into that jugular vein in the neck, which we saw here, right? So pretty slick procedure. And we do a lot of these for not just for colorectal, for all kinds of cancer. So same thing, outpatient procedure, generally quite well tolerated. We happen to do these with a combination of sedation and local anesthesia, and it's a very stable venous access device that can not just be used to administer systemic therapies, but also to do blood work, which saves you a lot of needle pokes. So if we pivot now and start talking, those are kind of the routine things, and we sort of pivot to some of the therapeutic things that we offer in interventional radiology. One of the common treatment options that we do in IR is thermal ablation of liver metastases. So we have lots of fancy words. You kind of have to be a Latin scholar these days to be a physician. So what does that really mean? So really, ultimately, we're using heat or cold to eradicate solid tumors in the liver. Now, we happen to do this in the liver, the kidney, and the lung, and some bones as well. But in this for this particular talk, I'm going to focus on the liver. And this is another outpatient procedure where we place a specialized needle through the skin into the liver and liver tumor using either ultrasound, CAT scans, or both. That's our whole shtick, right? I need imaging guidance to do what I can do. And that specialized needle will use different energy, either RFA or microwave, to burn the tumor as well as some of the surrounding liver. Our goal really is to not just burn the tumor, we want to get a margin, just like a surgeon would get. Surgeons don't just take out a cancer, they're going to take out a cancer as well as some normal tissue around it, because they want to have they don't want to leave behind any microscopic disease. Okay, and so we want to operate on the same principles, that when we burn something, even though it's a minimally invasive approach, we want to really treat the tumor as well as have a good margin of normal tissue surrounding. That's kind of a schematic how it would look, is we kind of use an ultrasound probe the vast majority of times. Sometimes lesions can be difficult to see with an ultrasound, so we might need a CAT scanner as well. And we would sort of place this probe. This probe particularly has this kind of what we call an array, but most of ours are just straight needles. And then we sort of will, once we're happy with our position, then we give some sedation and fire up the machine. We have different technologies. So if you're an engineering buff, there's different technologies we can use. RFA has been the workhorse technology for years and years, but really in the last, I would say 10 years or so, microwave has really supplanted, so to the point where I don't think they're going to make RFA generators anymore. And really the market has decided on microwave. We do use something called, so that those are where we heat up the tumor. Cryoablation is where we put these specialized needles that will form ice balls. But we don't tend to use that a lot in the liver. That's something we use more in the kidneys and the bones and things like that. And then there's a non-thermal technology called IRE, or irreversible electroporation. Once again, some more fancy talk to impress you, make us sound smart. But really what you're doing is you're kind of creating a voltage in between these two electrodes and sort of disrupting membranes at a cellular level, right? So kind of, but I don't use that, so I couldn't really tell you much about it other than the theory. So this is kind of an example of a patient I treated some years ago. So I may just pause the movie for a second right at the beginning there. Okay, so hopefully you can appreciate this is an ultrasound image that's really, I'm circling the liver here. Okay, and then this is a big vein here called the IVC. This is a vein called the right hepatic vein. This is a vein called the portal vein. So we're kind of seeing some anatomy. And we're looking at the normal liver, kind of what we call echotexture or appearance. And hopefully you can appreciate there's a little ping pong ball back here. Okay, and this line, white line back here is the breathing muscle or the diaphragm. So there's a tumor that's kind of nestled right by the breathing muscle. Okay, so what we do is I can see this. If I can see it, I can believe it. And if I can see it, generally speaking, I can target it with a microwave probe. So under ultrasound, after I kind of froze the skin, maybe I've marinated a little bit of sedation in there, but we don't really knock our patients out. I always say, I give booze analogies. It's like a rum and coke or a tequila shot or two, just to kind of get you nice and mellow. And once you're frozen, we sort of advance this needle through the skin, through the meat of the liver. And my shtick is to really target the center of this tumor and really, using my imaging kind of expertise or intervention expertise to kind of, even though I'm looking at a two-dimensional image, I'm really trying to target it in 3 dimensions. And I've kind of feel pretty happy about that. So I fire up the, let me just fire up the microwave, and then we get this kind of white, because it generates nitrogen gas, and gas is not our friend on ultrasound, so it just turns into like a snowstorm. So you don't really see much, and then that's that. Okay, so that's what an ablation procedure looks like on my end. On the patient's end, they got a needle sticking out, and we give them 3 shots of tequila, so hopefully they pass out, and we barbecue the heck out of them, and then they wake up and they say, when are we going to start? And that's a perfect ablation procedure. So what's the patient experience? It's an outpatient procedure in general. We get an IV for sedation purposes, and we're generally doing these in an IR suite, so we're either using a CAT scanner, ultrasound, or both. Most centers are using IV sedation. Some centers do these under a total anesthetic. I would say I'm probably a 95/5, mostly IV sedation, but if I have the odd patient that turns into like an orangutan where they're jumping off the table, then we kind of say, okay, we should get them an anesthetic. When I see patients in my clinic, if they say, I'm not letting you touch me without an anesthetic, I don't generally fight with them. I say, okay, because we have good access to our anesthesia colleagues. And the burning can be a bit uncomfortable. That's one of the other advantages of microwave is the burning's a little bit shorter and sweeter compared to the RFA. But so we do sedate them. We try to time the sedation for the burning. And we'll observe them for a few hours and then send them home. And then I see them back in my clinic, usually around 4 to 6 weeks, and I'll repeat imaging because that's how we tend to follow. Did we get it, right? Did we get it or did we leave a little bit behind? If I left a little bit behind, then I may have to go back and touch things up. I might repeat blood work, but most of the time I don't. Okay, what are the risks of an ablation? Really, bleeding is the biggest one. I would say, that area that we burn could get infected. We could cause some collateral damage. So it's just like real estate, location, location, location. So if it's in a good spot, like, even that spot that I showed you, it was near the breathing muscle, so I could cause some damage to the breathing muscle. People can get shoulder pain, and when we're burning near the diaphragm, that's where we feel it, is in the shoulder. We don't want to be near major bile ducts, major blood vessels, the colon, the bowels. And there's some tricks that we can do. If I'm near the colon, I can inject some fluid to kind of create physical space and displace it. But I would say the risks are relatively uncommon. We do a lot of ablations. I cannot say I've never seen a complication. I've definitely seen complications. We have caused some colon injury rarely. We have seen some bleeds. But honestly, the risk of major hemorrhage is quite rare, both in practice and in the literature. So who do we treat? We are generally treating people who are not good candidates for surgery, because surgery has better data and outcomes. Or we can do it in combination with a liver resection. So maybe they'll lop out one part of your liver and go barbecue the other part if there's some smaller tumors. Or maybe someone anatomically would be great for surgery. However, they have too much stuff going on. Maybe they don't have great heart and lungs. Maybe they're a bit, kind of weathered in a sense. They have a poor, what we call performance status, some functional limitations. They're a bit tired. They're not going to do well with a major operation. And we like smaller lesions. There are some engineering limitations of these devices. So we're not going to burn very large tumors. The best are really if they're less than 3 centimeters. And sometimes patients are a great candidate for surgery, but they say, they Google, Dr. Google knows lots. So they say, I want to have the ablation procedure. And our goal of care is curative, recognizing that, colorectal cancer is a systemic disease. So we do have to recognize that, ideally this is done in conjunction with chemotherapy, or at least under the close observation of an oncologist who's really kind of quarterbacking the care. So this is just an example of a picture. This is a fancy place in New York where they did these PET scans, and you could kind of see a CAT scan. So CAT scans are kind of like we're chopping you up like a slice of salami, like making slices. So this is a slice of this person's upper abdomen. So where my mouse is kind of the right side of the body. The spine here is the back. This is the front. And I'm circling this gray thing here is the liver. The white things are the blood vessels. And you can kind of see there's a little spot here that's a tumor. And so they have placed this, oops, I hate when that happens. They've placed this probe there, and then they happen to do a PET scan at the same time because they're fancy and they have access to these really cool rooms, sponsored by who knows, but we don't have that, so we're not as fancy. But and then they could do a PET scan afterwards to show that they've got a really good margin. Like you could see how big the tumor is, and see this black spot is how big they burnt. We want to burn more and have a good margin to get rid of any microscopic disease. And so that's kind of how we don't do it like that. We just sort of do it under ultrasound plus or minus CAT scan, and then we'll see the patient in follow-up. So doing all this, is there a point? Are we looking for local control in the liver, or is there in fact a survival advantage? Well, there's a trial that they did in France where they looked at this kind of information, really looking at about 120 patients, and they kind of randomized patients to having just chemotherapy or systemic treatment alone versus systemic therapy plus ablation plus or minus an operation. And their primary endpoint of that study, or the major point of that study, was to look at overall survival. And you don't have to be a statistician to kind of say there's definitely a wide gap of those curves over time, and that the local and systemic group, which is the kind of dashed line, had quite a big difference in terms of survival on they call these Kaplan-Meier curves that we use these quite commonly to evaluate treatments. And so there's definitely a survival benefit in this particular study. And they also looked at progression-free survival, which is kind of a surrogate to overall survival in smaller studies, because I don't want to get too ballistic into statistics, but when they give you the sugar pill and the non-sugar pill, to evaluate treatments, you really need large numbers of people to establish whether there's a treatment benefit or not. And it's harder in our trials and device trials, just because we're never going to have the numbers like you can with like a chemotherapy trial or something like that, for a couple of reasons. Number one, because big pharma's got bigger pockets than the device companies, and number two, it's just not as technically feasible. But the bottom line is both progression-free survival, which is kind of a surrogate for overall survival, and overall survival did show a benefit. And so they concluded that really aggressive local treatment can prolong overall survival in patients with unresectable colorectal cancer. So even though you may not get cure, if they have kind of ablatable, quote unquote, ablatable disease in the liver, they sort of advocate for that. And that's certainly been our approach at our center. Now, if we switch a little bit and look at Y90, so really Y90, what in fact is Y90 before I talk about the rationale? So Y90 is a radioactive isotope. Okay, how does radioactivity work? Well, you have something that is decaying. It's an unstable radioisotope that will decay into a more stable radioisotope. And in the process of decay, it will emit some type of energy. So there's different types of radioactive or radioactivity. This happens to be a beta emitter, so it's a high energy emitter. So it emits kind of beta radiation or beta particles. And ultimately, sorry, that's my pager, so we'll ignore that for a second, but it'll emit this radiation as it's decaying to its more stable form, which is zirconium-90. And so we like to deliver that to the liver via millions of tiny beads that will kind of be delivered through the blood vessels, through the arteries in particular, which tend to feed cancers. And so what's the rationale behind this? So first of all, if we take two steps back, whether it's external radiation or Y90, we know that radiation is lethal to cancer tissue if given at a sufficient dose. But we know in the liver in particular, the normal liver is quite sensitive to radiation, and it can be lethal. If we zapped your entire liver, you can go into liver failure and die, right? And obviously we don't want to do that. So with these Y90 spheres, and these are tiny little millions of little spheres that are like the size of human hairs, unlike external radiation, we can kind of deliver millions of these high dose point sources of radiation that will ideally preferentially localize into tumors and kind of ideally spare the normal liver. And therefore we can kind of deliver these high doses of radiation. So it's this form of internal radiation where we inject millions of these little radioactive microspheres into the liver arteries and targeting the tumors. How do we do this? Well, we do angiography. Okay, so what is angiography? It's really visualizing the blood vessels of the liver. Just like people, I'm sure everyone knows somebody that had an angiogram of their heart, right? So they might have had, some kind of heart blockage, and so they went through the wrist or the groin, and they traversed the arteries and injected dye into those arteries in the heart to kind of map out where the blockages are. Well, we do the same thing in the liver, okay? And so we kind of map out the vascular anatomy of the normal liver and the liver tumors. And so this particular treatment involves a mapping procedure, and it involves a therapy procedure. Okay, so the mapping is where we spend a couple hours, going through the blood vessels either through the wrist or the groin, after freezing the area, after giving some very mild sedation. To be honest, we don't have nerves in our blood vessels, so you don't really feel anything. It's just kind of boring, and our table is not very comfortable. But we give you drugs to kind of mitigate that pain, and then we chat you up and put you to sleep. And yeah, mostly people are just hanging out on the table and potentially watching the big screen, and we'll kind of navigate our way through the blood vessels into the liver and shoot the dye. And I'll show you a little bit of a schematic. So this is not a cartoon of Y90, but it's just a cartoon of how we do the older procedure we used to do called the chemoembolization. So you can kind of see there's this big blood vessel, right? If we kind of entering through the groin, I tend to do a lot of this through the groin. We sometimes go through the wrist artery as well, and then we have to go all the way down into the liver, whereas the groin's a bit easier. Go up and we hook into this liver artery with our little catheters or devices, and we shoot dye. And ultimately the goal would be to kind of shoot the radioactive spheres. This is what that angiogram looks like. It's called a subtraction angiogram, right? So we can kind of see that same catheter, and the black stuff we see is the dye. So that's what happens when they do an angiogram of your heart. That's what it looks like when they do an angiogram of the liver. We subtract out the bones and all this kind of stuff, and all you can really see is this, dye. And I call this the Google Map day, right? Because we can say, okay, I see this tube here, this tube here, and then I see it filling this huge ball, which is the cancer, okay? But then I say, oh, this guy's going to the spleen. I don't want to inject any microspheres there. This guy's going to the gut, and that's filling of this pancreas and the stomach. We don't want to put any kind of radiation into there and cause all kinds of complications. So that's where we kind of spend a lot of time and be very meticulous in the mapping. And that's just another kind of cartoon showing the same thing, where we inject those little microspheres. And if I kind of blow that up a little bit, there's your tumor, but really we're not, it's an indirect form, right? That we're kind of delivering these spheres into the blood vessels of the tumor, and they'll just sit there and kind of zap it. So as it's decaying, and it really relates to the half-life of whatever radioactivity. This happens to be 2.5 days. And then really after 3 half-lives, really most of the Y90 is gone. But that's what we want, because that's why when you get regular radiation therapy, the cells are only susceptible to radiation at certain points in their cell cycle. I don't know if there's any big biology buffs in the crowd, but our cells undergo these cycles, and there's particular points of the cell cycle that are susceptible to radiation. So that's why radiation oncologists will fractionate their therapies. They will give you radiation every day, maybe Monday, Tuesday, Wednesday, Thursday, Friday. Why do they do that? Because the cells are susceptible to that DNA damage and things like that only at certain points. So, the Y90, instead of having to come back multiple times, it's sitting there decaying, and it's fractionating the radiation just by sheer nature of its half-life. So what's the patient experience, right? So there's kind of 2 to 3 parts of the outpatient Y90 treatment. So it's an outpatient procedure. They come for that mapping day, go through the groin. We kind of map out the liver with our different angiograms. And I tend to repeat their CAT scans that day. And plus we ship them off. We do inject something radioactive on the mapping day, but it's a test. It's not there's no therapeutic element at all, but we use all that information to kind of calculate a dose of radiation. And then we either bring them back for 1 or 2 different therapies. I don't treat the whole liver at the same time. So if they do need to be the whole liver to be treated, we kind of will stage that a little bit. Both days, it's a couple hours on the table. Both days they're going to go to nuclear medicine afterwards. Both days we tend to go through the groin. We recover them for a few hours and they go home. And both days they feel like I didn't do anything to them. Okay. The days to follow, though, they might have some kind of, what we call a post-embolization syndrome. They might feel kind of some abdominal pain, some low-grade fevers. The biggest thing people will feel is a bit tired, and that might last a few weeks. What are the risks of a Y90? Well, anytime we do angiography, there's a risk of bleeding or damaging the blood vessels. That's pretty rare, though, probably maybe on the order of like 1 to 3% that you need like an operation or a blood transfusion, something like that. We're a pretty high volume center, and it's not to say, obviously, if you're the dumbest guy in the world, but you do something a lot, you get good at it, right? So we're a high volume center, and it's when you do things a lot, things tend to go very smoothly, just because it's like not just the doctors, the nurses, our technologists, like everybody is we're just used to it. So, we could run into infection. The area that we radiate could get infected. I've seen that once or twice. It's mostly in people that have had things like ERCPs or operations to their bile ducts, and the McDonald's now is lining your bile ducts. And, in most people, you have a nice valve preventing backflow from the gut into the liver, into the bile ducts. But once we disrupt that on purpose, then, well, McDonald's will show up wherever. We can run into problems with GI ulcers if we, shoot radiation beads into bad places. And we can also run into issues with, as I mentioned, the liver is sensitive to radiation, right? So we don't want to induce liver failure, and we don't want to cause radiation-induced liver disease, where they can get almost like a hepatitis or inflammation of the liver, and it can progress to liver failure. And we've seen that a few times in people who have kind of tenuous liver function. The problem with metastatic colorectal cancer is sometimes the numbers look good, but the livers are a bit chewed up and beat up from having multiple lines of chemotherapy and things like that. So it's just something we have to keep in mind. And we also have to keep in mind, where am I meeting this patient? I'll talk a little bit about this, but are they on first line chemotherapy? It's almost like treating cancer sometimes is like a boxing event, right? Are you catching someone in round 1? They have their gloves up and they've got all the energy in the world and they're swinging hard. Or am I catching them later, where they're tired and they don't have the energy, they don't have the swing, they don't have the punch, right? So So that's where we have to really use our judgment as healthcare professionals to even decide, is it a good idea to treat somebody? Because there is always a downtime, and there are side effects of treatments, and someone's got to have enough reserve and an ability to withstand these treatments to recover. So I talked a little bit about this post-embolization syndrome. I would say pain is less common. Really, fatigue is the most common. And we do put people on some precautions. They're not a danger to society. There are some radioactive treatments that are kind of, secreted everywhere, and we have to lock those people in the basement, for a bunch of time and protect society. This thing sits in the liver, and it doesn't go in your blood. It doesn't go in your saliva. So there's no issues with eating or drinking. It doesn't go in your urine or your stool. No issues going to the bathroom. But we just say, as a precaution, to sleep in separate beds, for 3 days. We just say to keep a meter distance. We don't want you to treat them like a pariah, but we say, hey, if you've got a 3-person couch, maybe keep the middle seat empty, and you can, watch some TV with them, but don't sleep in the same bed. And we try to avoid children and pregnant women for 7 days. I've added pets now, because I had a patient who had a cat that sat on the lap, and the cat got radiation sickness, I think. And now I tell people, no pets on the lap for a week. So at what point should we consider Y90? Most people are kind of unresectable at diagnosis, right? Although that's starting to change a lot with good colorectal screening programs. But really, in the metastatic setting, a lot of people are just not resectable. Okay, so people that are borderline resectable, I think there's a role for us to treat, and kind of, we call it downstaging, right? By shrinking the tumor, making things smaller, we have that ability to potentially downstage. But for people who don't have resectable disease, we don't really have a good defined role. There's even some anecdotal things that people who are on kind of prolonged chemotherapy, but they want to do what's called a chemo holiday, sometimes we'll throw Y90 in there just to kind of bridge that time, to give them a break from chemo and the side effects. But I can't say we have a great defined role of Y90 in this space. We have a very good defined role in other types of cancers, but in the colorectal world, we're sort of continuing to learn. There are clinical guidelines from the Europeans and the Americans. The NCCN are pretty widely utilized, but they're not definitive. They tend to, talk about patients that have metastases that are refractory to chemotherapy, but they're not sure about in the earlier lines. But ultimately, we kind of need consensus, right? And we need consensus when we need to treat, and then how do we sequence that with systemic therapies, and then how do we know what are the specific roles really for these kind of systemic therapies, surgery, and ablation Y90. Though these are kind of evolving areas, and a lot of it has to do with the evidence we have, but the evidence is a bit limited, and also what is your local expertise and your local experience. And then, so that it does lead to some unanswered questions when it comes to Y90. So we're not 100% sure when really to consider it. So like I said, a lot of that's going to be based on your local expertise and what therapies you have to offer. How do we optimally, optimize that dosimetry, that we're really treating the cancers and sparing the liver to get a meaningful response? And how do we sequence it? Although how to sequence it, I would say we have, I think, a pretty good handle. We tend to just skip a dose of systemic therapy. And then, how do we kind of incorporate Y90 in conjunction with immunotherapy, which is kind of the new kid on the block? So now we can pivot a little bit to something called portal vein embolization. These are terrible marketing. Whoever markets for my specialty needs to be fired, right? These are like words that conjure nothing in your brain, right? Like, what is portal vein embolization? So this is, if we take 2 steps back, it's something we do to improve outcomes of liver surgery, okay? What's the rationale? We need our liver to survive. It's not like I can pluck your kidneys out, you can have dialysis, okay? If I pluck out your liver, you're in trouble, okay? I can pluck out your gallbladder, your appendix, you'll live. Even your spleen, you may not live as long, but you'll live, okay? But we need our liver to survive, and we need a certain volume of liver. So really, if they operate on you and we don't have sufficient liver volume afterwards, you'll develop a dreaded complication that haunts every liver surgeon, is kind of post-operative liver failure, okay? And so what we do is we do this procedure to kind of fatten up the portion that's going to stay behind so that we can kind of make it enough, right? Because it may not be enough before we do anything, but we're going to make it enough, okay? And so how do we do that? Well,
Five
we
minute warning.
5 minute warning. Oh man, geez. Okay. Let me just see real quick what I got. I can power through some stuff. Yeah, I think we're good. We're good. Okay. Um, I just wasted 5 minutes now looking at all this. Okay, here we go back. Uh, so we use ultrasound to kind of look at the liver because I can't access the portal vein. It's kind of this unique vein that drains the gut, and I have no real access to it unless I stab the liver or the spleen, and I'd rather stab the liver. So we kind of bring people to hospital. We tend to do these under an anesthetic. I'll still freeze you. I find the portal vein under an ultrasound, and I tend to poke the side that's going to go in the bucket, right? The part that they're going to chop out and put in a bucket, which in this particular case, usually it's the right part of the liver because the left part of the liver is smaller. So this is the part that we're going to keep behind, but it's tiny. We need more meat, right? I don't want like a little filet mignon. I want a good like T-bone or porterhouse, or maybe a tomahawk. So I'm going to access this right portal vein and we're going to inject material there to block this. So the flow is heading back into the liver. And we inject, to be honest, a crazy glue, like a crazy glue mixed with this like oily stuff. And it's a beautiful picture. I'll show you what it looks like. And it will induce shrinkage of this side and growth of it signals the other part of the liver to grow. Okay, we do it a lot of times with a GA. We access it with an ultrasound. We use live X-rays as well, and we do some angiograms as well. And we admit people overnight for pain management. There are some risks: bleeding, infection. Right, there's a theme of everything I do. It causes bleeding and infection, and we don't want any of that crazy glue to go on the side that they're going to keep behind, right, the left lobe. So we have some measures we do to protect that, and they can get a bit of a post-embolization syndrome, right? So there's this little immunologic thing that can happen when we block things, right? A little fever, pain, feel like crap for a little bit, but then you recover. And then who are we going to treat? We're going to do this for people that are surgical candidates, but they don't have enough future liver reserve, okay? And we tend to review these patients in a multidisciplinary rounds with our surgical colleagues and our oncologists. And we can also do this while on chemotherapy, which is important because we don't want those metastases to go rampant, and then we did all this for nothing, right? So this is kind of what it looks like on an X-ray is we sort of have this angiogram business, right, where we're in that portal vein, we're shoot and die. That's the left that we don't want to touch. This is the right. We inject the crazy glue and we get the heck out of there, okay? And it's a kind of a nice, although, I don't know, this is from a paper. It's not as pretty as it usually looks. And then when we do a regular MRI and an MRI afterwards, you can see that look at this left part of the liver, and that it's fattened up quite nicely. And we do volumetric assessments. We can do some nuclear medicine assessments, and we want to see that functional growth has happened. We can also do the same thing with Y90 or portal vein to kind of fatten up the liver. The Y90 takes longer. The PVE takes about 4 to 6 weeks. The Y90 takes about 3 months, but you get a bit of tumor control. You don't get any tumor control with the portal vein embo, but you can always, and if you did the Y90 and it didn't work, you can also do the portal vein embolization afterwards. And I'll quickly kind of run through some of the palliative procedures. We talked about this. Really, our goal is to kind of, this is really more at the end stage or when things aren't going so well. And we're really going for patient comfort and minimize trips to hospital. We talked about the drains for the fluid buildup, the colon stenting, and these pain procedures. I'll kind of, I don't know if we really need to go, but all of this stuff really highlights the importance of a multidisciplinary collaboration where we really put the patient in the center and we have good collaboration amongst different medical specialties, whether it's interventional radiology, radiation oncology, medical oncology, surgeons. We kind of, and there's even other players in there as well that we kind of work together. And it's no longer like me or you. It's really me and you, and really trying to sequence different types of therapies to maximize bang for our buck. And not only just physicians, there's multiple kind of healthcare professionals, right? Whether it's nursing, dietitians, physio, OT, in my case, medical radiation technologists, radiation oncology technologists, right? There's all those kind of people that are involved in the care with cancer, and they have a huge role to play. And then we also involve a lot of home care, and palliative home care are integral as well. And at the end of the day, treating cancer is really a team sport. And I don't say that, in any light fashion, but it takes a village, right, to treat cancer, not just with physicians and with, all these other allied health and people's family and people like yourselves, right? Cancer coaches, which sounds like an amazing resource, really to help people in this really terrible time in their life. So in conclusion, I think IR plays a significant role in the patient's journey with metastatic colorectal cancer from diagnosis, including treatment, all the way to end-of-life care and palliation. And we ultimately work in these multidisciplinary teams to determine the best treatment courses in consensus. So thanks for your attention, and I welcome any chat or questions. How's that for timing? Are we good?
Perfect. Absolutely perfect.
Amazing.
Dr. Mujoomdar, that was absolutely fantastic. Thank you so much. Interventional radiology questions are quite common, and we know our coaches and silent viewers will take great knowledge from today's both wonderfully engaging but also exampled session. So thank you so much for that diligence. Silent viewers, once again, we will head back into the lobby to join the next session, which will be at 4 o'clock after a small additional health and stretch break, and we will be joining Dr. Knapp. Coaches can now also head backstage for our question period, and we will see everybody again at 4 o'clock.